Good afternoon, everyone. Thank you for coming. We have to start because we had to finish by 4:15. So we have today a session that is called Ards Management. We have 6 talks, interesting talks. All the speakers known for most of you. And I really want from every speaker to make, the 15 maximum time for the talk, because we have only, if they pass the time, so we have only time for 1 question maximum, or even 2, depending on how long is their lectures. So the first lecture is, I'm going to moderate the session with my friend Leo Hongs from Amsterdam. And the first talk is going to be open this session. Antonio Pesenti from Milan is going to talk about matching respiratory pathophysiology and lung imaging.
Thank you very much, Jesus. Thank you, Leo. Try to fit in the 15 minutes, if this works. Good. These are my conflict of interest. And my first slide is about the revolution of CT scans. CT scans defined ARDS from a bilateral involvement, diffuse, to a specific pattern with consolidated areas and ventilated areas on which a series of considerations and pathophysiology has been built. First of all, CT scan allows the measurement of the lung weight. I think it's the reference method to measure in vivo the weight of the lung. And it's very effective. And this is a very old slide that shows that we were able to measure lung weight in ARDS patients, showing at that time we still called it acute respiratory failure. Because otherwise you have, is a classical ARDS, it's not ARDS, high flow nasal cannulas, is that ARDS or not? If we call everything acute respiratory failure with a cause, we are all friends. And the weight of the lung is increased by the inflammation and or by edema from 1 kilo to 2.5 kilos is an example in this group. And then we can discuss the amount of collapsed lung or the amount of ventilated lung. And we see that gas exchange largely follows this pattern. PO2 follows the amount of ventilated tissue, while intrapulmonary shunt follows the pattern of densities. And when we apply PEEP in this set of patients, we could see densities decreasing, shunt decreasing, PO2 going up, and normally ventilated tissue going up. Obviously, this is a very specific case. It's not a rule, but you can follow what is going on. CT scan allowed also the demonstration, the evolution of the concept of baby lung, the fact that the ventilated regions are the ones that can get damaged by ventilation, and moreover, compliance is proportional to the amount of ventilated lung. So when the compliance is cut by half, normally, with good approximation, the amount of ventilated lung will be half of the normal size. So the concept, the pathophysiology we bring home from these approaches are that in ARDS, the lung is not stiff. The lung is small. And this is true particularly in the initial phases of the disease. We can follow what happens when we prone patients. Even if now, after 30 years of investigations, we are unable to connect the changes in blood gases with proning with the chances of survival. But what we know is that proning redistributes the densities, increases the aerated lung, makes the ventilation more homogeneous, but we cannot connect the change in PO2 with an increased chance of survival. This has an inherent message that is, sometimes proning patient is work, and sometimes I hear the comment, well, we proned him, but it did not improve. The original study did not get enough data to connect the changes, the improvement in blood gases with an improved chances of survival. So actually, we do not know. CT scan has been used particularly to measure lung recruitment. And obviously, there are patients that recruit a lot and patients that recruit a much smaller amount. We have high recruiters and non-recruiters. Here, too, we have to understand the message, because we could get the idea that patients, recruiters, big recruiters, have a higher mortality. Big recruiters have a higher mortality. So, is recruiting bad? I don't know. But for sure, this doesn't mean anything, because if I have a lot of lung to be recruited, it's because I have a lot of lung collapsed. So it's obvious that if I have a lot of recruitable lung, I'm much sicker than Jesus that has zero recruitable lung, because he's healthy and there's no collapsed lung. Okay? Now, the most recent advancement is the dual energy CT scan that allows us to follow not so much the perfusion proper, but the distribution of blood, which in many ways follows the distribution of blood flow. The bigger the vessels, the higher the flow, usually. It's not exactly true, but it's an approximation. And here is an example. We could see the perfusion in COVID-19 patients with areas of decreased perfusion and in areas of increased perfusion. Moreover, when we connect compliance and the D-dimers, split fibrin products, we could identify, as an example, a group of patients with very high mortality. This group of patients are patients that have low compliance and high dimers. These patients with hypercoagulating and low compliance had a mortality rate almost double than the rest of the patients. This is again the study of vessels with the double energy CT. And this is important because it shows you that we have suicide. Come on. I will learn sooner or later. These collapsed white areas is probably a shunting area, generating shunt. And we might think that the perfusion of the shunted area is increased because it's an inflamed region. But in this scan, it shows that actually the perfusion of the collapsed area is decreased, but is increased the perfusion at the border of the collapsed area. So we are getting more and more information that actually challenge our prejudice about what is going on in the lung. Another important morphological approach is positron emission tomography that has shown that the entire lung is inflamed in ARDS, not just the collapsed regions. Even the normally aerated lung shows inflammation and captures fluorodeoxyglucose, showing that granulocytes there are very active in inflammation. I skip this because we have to save time. The last thing I want to talk to you is electrical impedance tomography. Electrical impedance tomography moved from photography to TV, and we can actually see the ventilation. We can see how the ventilation is homogeneous. We can see how much air we have, whether the air in the lung is increased or not, as an example by applying PEEP. And here you see the effect of increasing, as an example of increasing PEEP, and it shows that the end expiratory lung volume has increased, and you can compute whether there is recruitment or not. Here we have the effect of SIG. By applying SIG 1 or 2 times per minute, you see that the end expiratory lung volume increases and is maintained because the SIG makes a cyclical prevention of de-recruitment. What is this? Pressure support? Why use electrical impedance tomography in pressure support? Well, you see as an example here, this side we have a high level of pressure support, same patient with a very low level of pressure support, almost CPAP. And you see that ventilation is much better distributed with low level of CPAP, because here the ventilator works and makes an unphysiological displacement of the diaphragm, while here, with the contracting diaphragm, improves the distribution of the tidal volume. This is a pig with the ventilation distributed between right and left. Now, we clamped the left pulmonary artery. And what happens is that the left ventilation disappears. Mind you, this is ventilation. We clamped the artery, and the ventilation decreases because it's a reaction from the airways similar to hypoxic vasoconstriction. This fades off in 48 hours. This fades off in 48 hours. And this contributes to ventilator-induced lung injury because now the right lung is ventilated twice as much that it was ventilated before. And so at the end, this clamping one of the pulmonary artery on a mechanically ventilated pig causes ventilator-induced lung injury on the right lung with tidal volumes that were not generating villi in the control subjects. Important to notice that if we make the animal breathe 5% CO2, then the damage is prevented. And it's prevented probably because the constriction of the airways is prevented and the ventilation is maintained. We can use electrical impedance tomography to measure perfusion, and as an example, we have been using it to see matching. Okay. To see the matching of perfusion in COVID patients. And
they give you the opportunity to show the last slide.
Yeah, my time is off. And so we could demonstrate that in COVID-19, there are areas that are not ventilated and areas that are not perfused. Next, please. And so ventilation and perfusion are topographically not matched. And we could identify the areas of dead space and area of shunt. And by that, I think I'm out of my time.
Thank you.
Thank you.
Thank you, Tony. Please, one question. Time for one question only.
Do you want to know how this works?
So perhaps I can start with a question. Thank you for this excellent talk. You showed the paper by Lang in Lancet Infectious Diseases. I think your own work has also shown that most of the inflammation is in the areas of consolidation, right?
Yes.
It's the sickest part of the lung.
By positron emission tomography,
yeah,
we could divide ARDS patients in two groups. There are patients in which the inflammation follows the density of the lung. Areas very dense are more inflamed.
Okay, stop right there. So
but there is a group of patients in which this does not happen, and that are those with the worst prognosis.
But if we accept the idea that the consolidation is the sickest part of the lung, so conceptually, why would we want to open up a sick part of the lung? Why would we just leave it alone? It's the sickest part. Why just not leave it alone as it is?
Well,
why would opening up that part that is so sick make it better?
I make it simple. If you need to live with the lung, if the patient needs his own lung and his own gas exchange, recruiting has a meaning because it improves mechanics and blood gases. But if you have an external tool to take care of your oxygenation, I'm not sure that the recruiting improves the healing process. If a patient has lobar pneumonia, you don't put a tube down to expand that lobe. But at the end, most cases, the pneumonia with appropriate therapy goes away and the lung gets back to normal function. When we have 3 lobes pneumonia, we intubate the patient because he's hypoxemic, he's hypercapnic, and then try to recruit. I don't know whether this favors the healing process? Or is
The
just...
If you would accept that this is the sickest part, we could say we should perhaps just leave it alone if it's not just gravitational induced. So that's the idea of the one consolidation is not the other consolidation. If the consolidation is associated with high inflammation, perhaps we should leave it alone. Is that
Perhaps we should not recruit. The best could be not recruiting, but that is not always associated to improved survival.
Okay.
But Antonio, what he said is a good idea to do a randomized controlled trial in Milan.
RCT with PET. Thank you so much, Antonio. It's a pleasure and honor to introduce Lise Piquiot from Lausanne, Switzerland, and she's going to talk about when to measure esophageal pressure. And she's really an expert on this, so we are looking forward to your talk, Lise.
Thank you for this introduction and good afternoon. Then the question is, when should we measure esophageal pressure? These are my conflicts of interest. Nothing is related to this talk. First, we can look at what evidence-based medicine says. And there is Impedance 1 study. The idea was to compare two strategies. Sorry, I have the same problem as the previous speaker. Okay. The idea was to compare two strategies to titrate PEEP. First, with a PEEP FiO2 table, and second, using an esophageal pressure catheter, delivering 6 milliliters by kilo predicted body weight and targeted transpulmonary pressure at the end of expiration under 25 and at the end of expiration between 0 and 10. And this study was terminated early because there was a clear benefit on oxygenation in the esophageal pressure treated group. Only 61 patients were included. And on general outcomes, there was a trend toward better mortality. And then there was Impedance 2, published in 2019. The idea was the same, a control group with a PEEP FiO2 table strategy, relatively high PEEP in the table that was used, and a PSO strategy for the intervention group. A bit different. Here, the target was 20 as a maximum value for end inspiratory transpulmonary pressure, and the target end expiratory transpulmonary pressure was between 0 and 6. The primary endpoint was a composite endpoint that reflects the probability of having a more favorable outcome according to the group in which the patient is. And overall, this study is negative. The primary endpoint is the same in the two groups. Mortality is the same in the two groups. Ventilator-free days is the same in the two groups. Then, if we consider that all our ARDS patients are the same and that they all have the same physiopathology, we can stop here. But we know that it's not the case. And we know that ARDS is a very heterogeneous syndrome. This is true both for COVID and non-COVID-19 patients. PaO2 over FiO2 ratio varies a lot. The range of compliance is very wide, from very low compliance to nearly normal compliance. Recruitability is not the same for all our patients. Dead space also vary from one patient to another. And if we look at the current recommendations for treating ARDS patients, they doesn't take into account this heterogeneity. Just say that there is one way to do 6 milliliters by kilo, or between 4 and 8, depending on the recommendation you read. Use enough PEEP, and try to have plateau pressure lower than 30. But with that, we cannot really optimize mechanical ventilation in the most complicated patients. It is just impossible to individualize mechanical ventilation according to the specific characteristics of each patient. To discuss further, I'm going to tell you a patient story. This is Mr. P, 31 years old. He has morbid obesity with a BMI of 58. He has obstructive sleep apnea syndrome, a restrictive syndrome. He has CPAP at home during the night, and he has a story of asthma in childhood. He arrives to the ER because of dyspnea and confusion, and he was tested positive for COVID 4 days earlier. This is the initial chest X-ray. After a short trial of NIV, he is intubated because of persistent respiratory distress and severe hypoxemia. This is the first blood gas analysis after intubation. PF ratio is 63, pH is 7.35, PCO2 43, PO2 63. He is prone because of severe hypoxemia, and this is the blood gas analysis 16 hours later, still in prone position. He is sedated, paralyzed, has already inhaled nitric oxide, and is ventilated with volume assist control, 6 milliliter by kilo predicted body weight, 30 by minute, 17 of PEEP. Plateau pressure is 32, and driving pressure is 15. And that's at this point, we decided to put him supine again because of problems with the tube, basically. Then this was done, and with the same ventilator settings, now we have plateau pressure at 38, SpO2 at 82% with 100% of FiO2. There is no pneumothorax, there is no endotracheal tube displacement, then no easy explanation to this difference. And there are a lot of questions here. Are the ventilator settings optimal in prone position? Maybe yes. In supine positions, it seems it's not the case. What should we do? Decrease idle volume, maybe increase PEEP to try to recruit, or maybe should we move immediately to ECMO? And what do you do? Do you decrease idle volume to decrease driving pressure? Do you decrease tidal volume and increase PEEP? Do you increase PEEP? Do you start ECMO immediately? Or do you increase PEEP and insert an esophageal balloon to understand respiratory physiology and respiratory mechanics of this patient and adapt your ventilator settings? We've chosen the last option. Then why? This is the situation you have at the bedside without the esophageal balloon. You can measure the respiratory system compliance using the standard formula, tidal volume over plateau pressure minus total PEEP, but you don't know whether you have a chest wall problem or a lung problem or both, and you cannot measure the stress that is applied to the lung parenchyma. If you put your esophageal balloon, you can partition the respiratory system compliance in lung compliance and in chest wall compliance. And you can measure lung stress. And then targeting values that you consider safe. Just a point to be clear about what we can do with the balloon. The balloon here is in the esophagus. Because it's very near the pleura, it's a good approximation of the pleural pressure. And if you have the pleural pressure, you also have the transpulmonary pressure, airway pressure minus pleural pressure. And then you can observe your lung. And you have the pleural pressure minus the atmospheric pressure, which reflects the chest wall aspect. That's why esophageal pressure is interesting. And if you look at what you have during a recording, first you have, as usual, the airway pressure with the here plateau pressure and total PEEP. You can compute the compliance of the respiratory system with the ventilator. And in addition, you have the end expiratory pause here for esophageal pressure and the end inspiratory pause here for esophageal pressure. And if you subtract esophageal pressure to airway pressure, you have transpulmonary pressure. And this is the information on the lung. And using those values, you can compute the compliance of the lung and not of the chest wall. And then, by using standard formulas, you can also compute the compliance of the chest wall. The other interesting aspect of esophageal pressure is that you can use it to titrate PEEP. Basically, at end expiration, if transpulmonary pressure is lower than 0, you have collapse. If it's higher than 0, you probably have less collapse. And if you target a bit higher value, you can enhance recruitment. Then overall, when you put your esophageal pressure measurement system, you can measure lung stress, you can keep end inspiratory transpulmonary pressure under 20, which is safe, and you can titrate PEEP in order to have transpulmonary expiratory pressure between 0 and 6. This is, again, my patient at the same point as he was before. PEEP was increased at 23, and the esophageal catheter was placed. Now, plateau pressure is 42, end inspiratory transpulmonary pressure is 17, and end expiratory transpulmonary pressure is 6.8. The respiratory system compliance is 19, the lung compliance is 39, and the chest wall compliance is very low at 37. And doing that, you know that this plateau pressure is at that time for this patient probably not dangerous because the majority of the pressure is used to expand the thorax that has very low compliance. Then the patient improved a bit, but as he still had a 70% of FiO2, he was prone again. And when he was prone again, we did the measurement again. And at that point, plateau pressure is 44, end inspiratory transpulmonary pressure 26, too high, and end expiratory transpulmonary pressure 14, very high. Then we've decreased PEEP at 16, with values at 16 of transpulmonary pressure at the end of inspiration and 6.5 at end of expiration, again, in the target we have. And we've continued doing that, proning, supine, prone, supine, and doing the measurements every time and adapting the PEEP according to this strategy. And what occurred? The patient was proned 6 times, he improved. At day 9, neuromuscular blockers were stopped. At day 10, he was switched to pressure support ventilation. At day 15, he was extubated. At day 21, he was transferred to the ward. And 3 months later, he has no sequelae on the lung parenchyma. This was really a case that was managed using esophageal pressure to adapt the PEEP according to the situation that was not the same in supine and prone positions. And this is not only a one-patient story. If you look in the literature, you find this very interesting study performed by our Italian colleagues during the H1N1 epidemic. They took 14 patients who were referred for ECMO because of very severe hypoxemia. And they did exactly what I did with my patient. They used esophageal pressure measurements to optimize the ventilator settings according to safe zone of transpulmonary lung pressure at the end of inspiration and at the end of expiration. In 7 patients, it didn't change anything because transpulmonary pressure was already very high at the end of inspiration. They could not improve the settings, and patients went to ECMO as initially planned. 5 of those 7 patients survived. But in 7 other patients, for whom transpulmonary lung pressure was lower than the target they've set, they could adapt the ventilator settings, particularly in this situation, increase PEEP, and those patients were successfully managed without ECMO, and 6 of them survived. Very interestingly, those patients had all very low chest wall compliance. Then the problem was not the lung, basically, or not mainly the lung, but was also the chest wall. Also very interesting, you can see here that in the ECMO group and in the non-ECMO group, there was no correlation with BMI. That means that it's very difficult to predict which patient has a low chest wall compliance. And this is known from older data. Here, they compared very obese subjects, it's not patients, it's healthy subjects, with non-obese subjects, and there was no correlation between obesity and chest wall compliance. And this is an important message, because that means that we cannot know by default that a given patient has or has not a reduced chest wall compliance. In conclusion, the EPIVENT-2 randomized study on the use of esophageal pressure to titrate PEEP does not improve outcome. These were standard group of ARDS patients. But esophageal pressure measurements helps understanding respiratory mechanics, helps partitionate between the lung and the chest wall, allow the measurement of the lung stress applied by the ventilator, and allow PEEP setting. In my opinion, esophageal pressure should be considered in moderate and severe ARDS when you don't know how you can improve your ventilator settings. And not only in obese patients. Basically, our patient was probably, I would say, saved because he was very obese. And we thought that chest wall compliance was probably low. But this could have been the case even if in a non-obese patient. And what targets? If we should say, I would say that end inspiratory transpulmonary pressure lower than 20 and end expiratory transpulmonary pressure between 0 and 6 seems reasonable values. Thanks for your attention.
Thank you very much, Lise, for this very good and important talk, because as we know, more and more people are starting to use the esophageal balloon in their clinical practice, and it does, as you have shown, provide a very good insight into the respiratory physiology of the patient. Are there questions from the audience or comments? If you not agree?
Yes, over there. One question.
Please.
Can you go to the microphone? Is the microphone?
Please introduce yourself if you want. Right here, the microphone is right here. Oh.
Yes, it's okay.
Lisa, can you please repeat the question for the people in the back?
Yeah, the question is whether we can also use esophageal pressure when you switch your patient to assisted ventilation to help with titrating the amount of assist you deliver and maybe to measure the work of breathing. The answer is yes, you can. It's a bit more challenging because it's a bit more difficult to have very reliable values during spontaneous breathing along the time. Because when you use esophageal pressure in a static situation, You calibrate your system, then you do the measurements. Then usually your values are really very reliable. When you work along the time, you have to recalibrate the system to be sure that your values are really good. And to really adapt the amount of assist you deliver, you need to measure work of breathing or pressure time product, which is challenging currently with the ventilators. Then you need another system to do that. But it works, and we do.
Okay, we have one more question.
Yes, yes, Tolba. Just I'm asking about, thank you for the lecture, just about the reliability of the esophageal pressure, because I mean the positioning, the pitfalls, because in your case you raise that PEEP to 23, and if there's any mistake and you know, or incorrect measurement, this can be dangerous. I mean, is it, and also for centers who didn't use it before, I think there's a learning curve as well.
This is a very good point, and the story has changed a lot during the last 5 years. 5 years ago, the systems available on the market were difficult to use, and it was a nightmare to have reliable values. Basically, it was research. But now, with the system we have, and especially with the nasogastric tubes equipped with esophageal balloon, and the connection to some ventilators with an assist for the calibration and the position, it's really easy to do, it's reliable. You can have the same values if you have different operators, for example, and it's also relatively easy to learn. Then I think that it's much easier now, but of course you have to check your position, to check that you have the same depression in airway pressure and esophageal pressure before using your measurements. This is a bit as for Swan-Ganz catheter. If you don't have right measurements, you cannot interpret them. This is very important.
Okay, we have no time for more questions, sorry. Okay, thank you very much, Lise. Well, now we are going to two talks, the two sides of the same coin. The coin is called the spontaneous breathing, and the first author is going, the first speaker is going to talk about whether spontaneous breathing can be good in ARDS. And it's going to be by Andreas Meiser from Hamburg in Germany. He has their own portable computer, so.
Dear colleagues, spontaneous breathing can be good. These are my conflicts of interest. I received money from Sedana Medical, from Dahlhausen, and from Covidian Medtronics. Which one is better? Spontaneous breathing or mechanical ventilation? Well, for me this is quite clear. Spontaneous breathing exists since the Devonian time, 400 million years ago, and it has much improved since then. It comes along with a very fine and robust circulation, which is our brain. It works in very different environments. Whales in the water, birds high up in the air, animals in the Arctic and the desert, they all do spontaneous breathing. It works sometimes for over 100 years without any interruption and without malfunction. And it is natural and humane. On the other side, mechanical ventilation exists since the late 50s, first employed in Copenhagen during the polio epidemic. And it has little improved since then. It is poorly regulated, usually by a doctor coming along once or twice a day. It needs very special medical environment. It may work for a few years, but often it doesn't. Patients die of complications, and it is tantalizing and harmful. So, but sometimes we need mechanical ventilation. We need it in patients with brain damage, comatose patients, in patients with neuromuscular disorder, with bronchial disease, or with pulmonary disease like ARDS. Let's talk about ARDS. The pathophysiology of ARDS can be reduced down to one single molecule, surfactant, a big invention in life. It enabled life on land. Without surfactant, we could not be here. When surfactant is depleted or destroyed, the surface tension of the alveolar lining increases dramatically. This causes our lungs to collapse, and we would not be able to overcome this with our respiratory muscles. So we do need, so the lung will shrink, will become atelectatic, and what we do need is airway pressure, to say it with the words of Burkhard Lachmann, open up the lung and keep the lung open. But this does not mean that spontaneous breathing is impossible. What do we do to our patients? First, when we intubate them, first thing, the thorax wall will fall down. This will reduce thorax volume by 250 milliliters. Then the diaphragm will move upwards. This will cause a further reduction of 500 milliliters. And these 750 milliliters split up about 300 milliliters reduced central blood volume and 450 milliliters FRC, which is lung volume, and this means that some areas of the lung will collapse. These data are very old, from the group of Hedenstirner in Sweden, when CT scans became first available. But I think it's nice to repeat them. So this is the abdomen, not so important. Mechanical ventilation takes place in the ventral areas. It follows the path of least resistance. And that's there because in the dorsal parts, there's the high hydrostatic pressure of the abdominal organs. In the ventral parts, there's the intestine, small and large, partly filled with air and very easily displaced. In the dorsal parts, there's the liver, the solid organs, and the kidneys. And so we have a lot of ventilation in the upper parts, but there perfusion is poor. So we have ventilation-perfusion mismatch in mechanical ventilation. And in the lower parts, we get atelectasis. And it has been shown also spontaneous breathing is different. It works mainly dorsally. This is because of the geometry of the diaphragm. The diaphragm inserts much more caudally dorsally, and it is also much stronger in its dorsal parts. So it pulls the lower lungs open, and there is less mismatch in the ventral parts. This has been shown also ages ago in animal models. Mechanical ventilation also has an impact on hemodynamics. The airway pressure squeezes the blood out of the thorax, and there's no venous return, there is no preload for the heart, and no cardiac output. Spontaneous breathing decreases intrathoracic pressures, blood flows back, and cardiac output is reestablished. This has been shown by the group of Putinsen also ages ago, and the group of Herring have measured in clinical practice that there is a better kidney and a better splanchnic perfusion in invasively ventilated patients if they do spontaneous breathing. This is a newer study from Levine. They looked at biopsies, diaphragm biopsies from 14 brain-dead organ donors and compared them to biopsies from 8 otherwise healthy patients undergoing lung surgery. And they found a severe atrophy of the diaphragm already after as little as 18 to 69 hours of mechanical ventilation. Now, is this important for clinical practice, or does the diaphragm come back quickly? This is a rather new study from Golliger. They examined about 200 patients. With sonography, they measured the thickness of the diaphragm every day. And what you see is here, in the middle, patients where the diaphragmatic thickness had not changed were most likely to be extubated. When the diaphragmatic thickness was decreased a lot, the chances of extubation were much lower. But also here, when the diaphragmatic thickness had increased, the chances were also lower of a successful extubation. The author speculated this increased thickness may reflect edema of the muscle due to myotrauma, due to distress, too much work. So it seems probably best if the diaphragm, if you allow the diaphragm to work continuously, but without too much stress. There's one thing associated with spontaneous breathing that is bad. That is cough. Cough usually is a very useful physiological reflex. If we have something in our trachea, something irritating, mucus or foreign material, we will close our glottis, we will exert pressure, then we will suddenly open up the glottis, and the resulting high flow will blow out everything out of our trachea. In our patients, this doesn't work because the endotracheal tube is going through the glottis and they cannot close their glottis. And if they exert pressure, there will not be such a high flow, and instead the lungs will be pressed, they will shrink, and there will be atelectasis, and this is no good. Therefore, some use muscle relaxants in severe ARDS, and this is a trial in favor of using muscle relaxants. It's about 10 years old by the Papazian group in France. 340 patients with severely impaired oxygenation were included. This atracurium was given for 48 hours. This study was blinded. This means that the control group also had to be sedated deeply, down to a Ramsay score of 6. We know that sedation, deep sedation, is no good. They also used volume-controlled mode, and I think mostly in European ICUs, volume-controlled, not pressure-controlled ventilation modes have taken over. The PEEP in their study on average was 9, which seems a bit low for severely compromised oxygenation. And they found a significant difference for the subgroup of very severe ARDS, or after adjusting for the PF ratio, because the PF ratio was unequally distributed, although the study was randomized. This is a following study. The Lobes trial included more than 1,000 patients. They used the same drug and the same dose regimen. Their study was not blinded because their control group was given only light sedation. They had a higher PEEP strategy and different other ventilation modes, and they did not see any differences in outcome, not in mortality and not at the time when the patients were discharged home. But is spontaneous breathing possible? Is it possible in severe ARDS? Is it possible in deep sedation? Is it possible when patients are groaned? Yes, it is. This is a study by Haider, the group of Freiburg. They followed prospectively 62 patients with severe ARDS. These patients were deeply sedated. Most clinicians will agree that for prone positioning, a rather deep sedation should be employed. And they were sedated with sevoflurane. And despite deep sedation, prone positioning, and severe ARDS, spontaneous breathing was possible in most patients over most of the time during prone positioning. This is a secondary outcome of our study that we published last week in the Lancet Respiratory Medicine. We compared inhaled isoflurane via the anesthetic conservative device with propofol for sedation. We did not include severe ARDS patients, I must say, but we found that it was a multi-center study. Many doctors were in charge, and we found that on the first day, spontaneous breathing was more common in the isoflurane group. You see the results of the whole study in the left graph. On the right, I show you the subgroup of our patients in Hamburg, 66. And you see that in more detail, every five minutes we were looking in the charts whether there was spontaneous breathing or not. And you see that the curves diverge quite early. So, my conclusion, spontaneous breathing should be preferred whenever possible, because it is natural and humane. It counteracts dorsal-basal atelectasis. It decreases ventilation-perfusion mismatch. It improves hemodynamics. It avoids atrophy of the diaphragm and thereby accelerates weaning. If we allow our patients to breathe spontaneously, less sedation is needed, and we know that sedation is bad. And with inhaled sedation, even if it's deep sedation, according to the RAS score, spontaneous breathing, early spontaneous breathing is possible in most patients. Thank you for the attention.
Thank you very much, Andreas. I think you have very convincingly shown us that spontaneous breathing is good. If it is okay with you, we'll now have to talk by Neil Ferguson, who more or less tried to convince us of the opposite, and then we have a more general discussion, if that's okay with you.
Sure, thank you.
Okay, then I'm happy to introduce Neil Ferguson from the Toronto General Hospital in Toronto, Canada. Obviously, he is an expert, of course, in mechanical ventilation, senior author of many clinical trials, physiological trials. So we're very eager to hear what his standpoint is on spontaneous breathing.
Thank you very much, Leo, for the kind introduction. Thanks to the organizers for having me here, and thank you for coming to listen to this talk. If I can get my slides up. Here we go. So these are my disclosures. When we're talking about spontaneous breathing and ARDS, we really have to focus on our mission with the ventilator, and that's to provide adequate gas exchange, but also primarily to avoid and reduce ventilator-induced lung injury. And this just reminds us that there's lots of mechanisms to this, but primarily this means overdistension, cyclic, repetitive overdistension, and high pressures. This is clinically important, and whether you're a 6 mils per kilogram for everyone believer or just let's avoid 12, regardless of whichever side of the debate you're on, this original ArdsNet study definitely shows us that the way in which we use the ventilator has a big impact on mortality. But thinking about spontaneous, oops, why that's there. Thinking about spontaneous breathing, now I know what's here, is every one of these trials, whether it was the ArdsNet or Lobes or alveoli, all have little footnotes in the tables where they show the tidal volumes delivered. And the footnote says, for tidal volume, exclude anybody who is on pressure support mode, PEEP of 10 or less, FiO2 40% or less. Already we're seeing lots of spontaneous breathing in these trials of lung protective ventilation. And I think it's becoming increasingly important. If we look at surveys of how mechanical ventilation is used over time, up here in the top left-hand corner is data from the 1998, the first international study of mechanical ventilation coordinated by Andres Esteban and colleagues. And the lines show different modes of mechanical ventilation per day for the first 28 days. And you don't have to read the graphics because there's a single winner up here. Everybody, the most commonly used mode of ventilation in the late 90s was old-fashioned, assist-controlled, volume-cycled mechanical ventilation. Everything else is down here. Compare this to 2010, and I suspect if we have a look at the 2016 data, it may be even more apparent. Still, volume control wins on day one, but by the second week, pressure support is the most commonly employed mode of ventilation across all types of patients, and this is true for ARDS as well. And as we already heard, we care about this a little bit because we're increasingly focusing, okay, our primary goal might be in avoiding ventilator-induced lung injury, but we're also trying to induce and reduce ventilator-induced diaphragm dysfunction. And there's emerging data to say that clearly doing the right amount of spontaneous breathing, not too much and not too little in terms of effort, can help the diaphragm maintain itself in a good functional state, and that's associated with outcomes. So why might spontaneous breathing be bad? If it's so natural and we do it, we're all doing it right now, great. Well, the point is that this is happening in patients with ARDS. And so, although we heard, yes, spontaneous breathing may help improve venous return, it can also change the interstitial gradients and cause and worsen more pulmonary edema. We also have concerns about this vicious cycle of patient self-inflicted lung injury, where we don't just care about ventilator-induced lung injury, we care about ventilation-induced lung injury. And whether it's negative pressure or positive pressure, that may change the way it's distributed within the lung, but it doesn't change the actual pressure gradients to which the alveoli are exposed to. This is a classic study from Koblov and colleagues showing that you can make sheep breathe a lot by injecting salicylate into the foramen magnum. They hyperventilate like crazy from respiratory rate of 25 to 70. So admittedly, this is an extreme example of hyperventilation. But these sheep developed, the hyperventilation group developed ARDS versus none of them did with when breathing normally. So you don't need a ventilator to cause ventilation-induced lung injury. Negative pressure can do this too. It also gets more complicated. As soon as you start having a patient breathing spontaneously, we have to worry about on a ventilator, we have to worry about two different sets of drivers. That's what you were doing with the ventilator, and what the patient's doing with their own respiratory muscles. And depending on the path, in somebody who has normal lungs, not so difficult, but in somebody who has significant lung disease that's heterogeneous, that can have significant impacts. And Takeshi Yoshida here in this paper has nicely shown this can lead to the development of Pendeluft, from the German swinging air. Literally, when you take what seems like a normal sized breath in, all of it goes to one area of the lung initially, and then all of it goes to another area of the lung secondarily, essentially doubling the tidal volume that each alveolar unit is seeing. And this may explain some of the reasons here in this experimental study that there's an interaction between the degree and the severity of lung injury and the impact of spontaneous breathing. So here in mild injury with no spontaneous breathing, mild injury with spontaneous breathing, obviously the spontaneous breathing pathology looks better. But in patients with severe injury, that is, not just saline lavage, but also saline lavage and ventilator-induced lung injury on top of that, here's severe injury without spontaneous breathing, severe injury with spontaneous breathing on top of it, much worse pathological injury there. And PEEP can also have an interaction here. If you have PEEP is not titrated properly and you have lots of de-recruited, potentially recruitable lung, this effect is magnified. More work by Takeshi Yoshida. This whole concept of, it starts getting complicated when we say, okay, well, before I was just trying to protect the lung, and now I'm trying to protect the lung and the diaphragm together. It brings another degree of freedom into your calculus. And as you can see here, all these issues, are nicely summarized in this sort of consensus paper that Ewan Gallagher led and published in the Blue Journal last year. So I think there are times when spontaneous maybe breathing may be bad. There also may be times when it may be good. So the question is when to allow. I don't think it's as black as white as yes or no. It's when and how much, and can we regulate the amount of spontaneous breathing? Because obviously we're going to allow spontaneous breathing at some point if we're ever going to get the patient off the ventilator. As we've heard, the pros for spontaneous breathing, great. We help keep the diaphragm active. It's never meant to, was never designed to rest. Maybe it improves hemodynamics. Maybe we need less sedation and its associated adverse effects. And we feel like we're making progress. But we may have issues because of direct overdistended injury, Pendeluft injury, increasing lung perfusion. As soon as you start letting the patient breathe spontaneously, now you're into issues with Asynchrony, double triggering, potentially worsening ventilator-induced lung injury, and expiratory muscle activation, again, leading to decreased end expiratory lung volume, potentially. So you have pros and cons, and then you have effect modifiers on this about how important these are, or which side of this coin you want to land on. I think depending on the ARDS severity, the smaller the size of the baby lung, the higher the drive that the patient has, the larger the efforts that they're making, and the potentially interacting with the settings of that you've placed on the ventilator. So if we're going to care about, we're saying, oh, fine, maybe there's a place for spontaneous breathing, but let's make sure it's not too much. We have to be able to measure it. how much effort is happening. Because just being on pressure support could mean I could be auto-triggering from my heartbeat, or I might be making huge efforts. And the ventilator settings don't tell you that. So you need to do something. But fortunately, there's lots of different tools we can use. As we've just heard in the previous talk, we can measure transesophageal pressures. You don't have to be that excited. The plateau pressure can be helpful. And not all ventilators allow you to do this, but in some ventilators, you can do an inspiratory pause and see that, in fact, the plateau pressure may be higher than the peak pressure in a bit of a oxymoronic way of things, where this rise in plateau pressure above the peak represents the amount of work that the patient has done. We can measure P.1. Most ventilators can do this for you and give you a sense of high or low effort. Irene Tellius has nicely shown this recently in the Blue Journal. And even if you have a ventilator that doesn't do P.1, almost every ventilator can do this simple end expiratory occlusion pressure, which just as an expiratory pause. And this correlates very nicely with more sophisticated measurements using an esophageal balloon, so that you can use this even as a screening test to say, I do an expiratory occlusion pressure, multiply by about 0.7 to get an estimate of P-mus, and take your measured delta P on the ventilator, and then subtract essentially 0.6 of your occlusion pressure to to sort of add in the effects of the spontaneous breathing to get a true sense of what's actually happening to the lung. Because your pressure support of 5 might mean a delta P of 5, it might mean a delta P of 35, depending on how much effort the patient's actually making. You can use PAV if you have this mode of ventilation as an indirect way of measuring effort. Don't have time to go into that now, but just to put it on the list here. And so then, okay, you've measured effort. Now it's high. What can we do about that? Well, you might increase the assist depending on how large the tidal volumes are, but be careful because you may just be trading negative pressure to positive pressure here. Increasing PEEP can help sometimes by increasing end expiratory lung volume, can decrease drive. We might consider sedation and neuromuscular blockade in extreme settings, but then at full doses, we're trading under assist for over assist. Something we've sometimes started doing, thanks to work done by one of our chairmen, is considering partial neuromuscular blockade, where we have low doses of depolarizing agents going. The patients are still able to trigger the ventilator, but are relatively weakened and not generating large forces. Or we consider using extracorporeal CO2 removal to blunt drive and bring down the amount of effort. And we know that in physiologically, we're generally driven by, in healthy subjects, we're driven by CO2, and you can make the minute ventilation go up or down depending on how much CO2 you move through the ECOR device. And this is also true in patients with ARDS, that as you decrease sweep, EDI goes up, tidal volume goes up. As you put sweep back up, same things come back down again. So you can modulate respiratory drive with this. In my opinion-based medicine about when to use spontaneous breathing or not, when the chest X-ray looks like this and you have severe ARDS, that's when I'm very concerned about measuring overall driving pressure and maintaining lower tidal volumes. When the X-ray is starting to look like this, and the elastance of the respiratory system has come down, then let the patient breathe spontaneously. Consider checking for pendulift and make sure they're not generating huge amounts of efforts, which they shouldn't be in that setting. So I've tried to show you that the impact of spontaneous breathing depends on ARDS, depends on the timing and severity. Measuring effort is, I think, important and easy to do. And when you are allowing spontaneous breathing, remembering now you're making the situation more complicated, you need to think about normalizing efforts to protect both the lung and the diaphragm, especially early on. And with that, I will stop and be happy to take questions. Thank you.
Okay, thank you, Neil. Andreas, can you please come up? Well, these two sides of the same coin is very interesting. The two speakers has a different point of views. So, and I think they require a question from the audience. because I don't think you have everything clear in your practical issue. Otherwise, in your clinical practice every day, I think this is the time to make the question. This is the time to make the practical question. The microphone. Yeah.
Thanks a lot. Thanks a lot for those very good presentations. I have a very practical questions. I totally agree that we have to monitor the amount of pressure generated by the inspiratory muscles, but how often do you monitor occlusion pressure, PO1, and inspiratory occlusion?
In our unit, we routinely, we work in Canada, we work with respiratory therapists, and our routine is that they sort of do major rounds every 6 hours, and we've just asked them to include a plateau pressure, a real plateau pressure, P.1, and an occlusion pressure as part of their 6-hourly major checks.
Well, we don't very often, but I think clinically you can judge a patient and see whether he is in respiratory distress, whether he has dyspnea, whether he uses his additional muscles to breathe in heavily, or whether he is calm and nicely, slowly, shallowly breathing. I think this is something you can judge with your eyes. And if I would like to comment on the study of Yashida with the rabbits that you were citing. In this study, rabbits, the lungs of the rabbits were severely injured. And then there were two groups of rabbits. One group of rabbit was sedated with propofol and dexmedetomidine and put on the ventilator, which is what we would always do with patients. The other group of rabbits, they had a severely injured lung. They were already at a respiratory rate of, I think, 50 or something, and they did not receive any sedation as we would do in our patients. They were given an additional respiratory stimulant, enoxaparin. And I think this study proves that we should not give enoxaparin to our patients. We should sedate them, and then we do not have the problem that is artificially drawn up in the study. I agree that too much spontaneous breathing can probably, in some cases, be bad, but much more often the problem in clinical practice is that the patient is nicely sedated, nicely ventilated, everything is stable, and we do too little efforts to get the patient from the respirator. Weaning should start from the beginning of the intubation. We know that sedation measured 4 hours after intubation. If patients are deeply sedated after 4 hours, and this means not breathing spontaneously, because with IV sedation you wouldn't breathe spontaneously then, this has an impact on mortality. So I think the bigger problem is that we do not let the patient breathe spontaneously. We do not think of it. We do not allow it.
Can I briefly summarize this part? If I understood it well, and both from a scientific and a clinical perspective, the only reason why we would not let patients breathe spontaneously is because we cannot control respiratory drive or basically respiratory effort. Would you both agree that in an ideal situation where we can quantify respiratory effort and can control the respiratory effort, spontaneous breathing would also be always be preferred?
Yeah, I think that may be theoretically true, but the truth is a lot of patients with severe respiratory failure have extremely high drive. Even our COVID-19 patients on VV ECMO, our dream is always to have the patients on ECMO. We're taking care of CO2 clearance. Of course, we want them to be awake and breathing spontaneously and ideally maybe even extubated. The truth is that almost never happens in the first several days.
But now conceptually, would you agree there's no other reason to, abandon spontaneous breathing except for that we are not able to control respiratory drive or effort? Or are there other reasons?
I think that's probably true, and because the other factor to consider is the synchrony with the ventilator. If you use a mode like NAVA or PAV or something like this, where the synchrony is good and the effort is not too high, the drive is not too high, then that's
ventilator modes. I agree.
Then that's good. The challenge is we often have patients who have very high drive.
Right, right. So that's, I think that from a physiological point, and then I'll give you the word, it's very important that we get more understanding in the generation of the respiratory drive, right? Because even in patients with high pH, low CO2, respiratory drive might still be very high.
Exactly.
Okay.
So we have only time for one more question.
Okay. Thank you for the lecture. What about Aprv? Because Aprv allows spontaneous breathing, and I know there's believers and unbelievers, but I think we do it and it works. And also about the use of spontaneous breathing, I mean, also it depends on the clinical stage of the disease. If early, obviously we don't allow much spontaneous, but later we will allow.
Yeah, sure. I mean, I think Aprv, like many things, it's a mode, but even more than most other modes of ventilation, it can be extremely different depending on how you use it. If you're talking about sort of classic, what I call American trauma surgeon Aprv with very high P high and a very long P high and a zero P low and a very short P low, personally, I think that's an injurious mode of ventilation where you see very large release volumes. Don't worry, they're release volume. Guess what? As soon as you go back to P high, then you're giving that same volume in. So I worry about giving tidal volumes of a liter, even 7 or 8 times a minute. And there's also cyclic collapse and reopening, even if you don't go back to absolute zero flow on expiration. If you're using it differently, where you've got PEEP set to prevent a lot of collapse, or you're using it as Alain Marcat and Laurent Bouchard used in the BIRDS trial, where it's really essentially set up like pressure control with short inspiratory time, but it's not generating additional help with every spontaneous breath, then maybe that's a different thing.
Short final word, please.
Thank you for this good question. The question to us was whether spontaneous breathing is good or not. The question was not what is spontaneous breathing, and that is another question. You can do spontaneous breathing by putting the patient to pressure support. You can use pressure-controlled modes. In America, this is called Aprv. And you can also use the mode that you were mentioning, proportional assist ventilation, which I believe is a really good mode, but it's not very frequently used. And I'm convinced that pressure-controlled modes, however you call them, duo-PAP, BiPAP, bilevel, or Aprv, if the pressures are right, of course, they must not be too much apart, and there must not be cyclic atelectasis and so on, are much more comfortable and better for the patient. And you were mentioning the problem of Pendelluft. This, for me, this is an old concept because it's linked to volume-controlled mode. There are areas in the lung that are quick and others are slower. And when you have a volume-controlled ventilation, flow goes in, all valves are closed, one part of the lung is full, the other is slower and takes the air from that lung. That is Pendelluft. That is no good. But in pressure-controlled modes, where the valves will open when the pressure decreases, there is no Pendelluft. And also, the question is, shall we adapt the patient to the ventilator, or shall we try to have good ventilators, as you said, with, for instance, with PIV, it is very easy to help the patient breathe. Shall we adapt the patient to the ventilator, or shall we adapt the ventilator to the patient?
I think that's a very good closing statement. Thank you very much for this lively discussion.
Well, we are going now to the last part of the session, and we are going. The next speaker is going to talk about lung recruitment, time to standardize, by Fernando Suarez Sidman from Madrid, Spain.
Thank you very much. I would like to start saying that this is the third talk I give around the same topic, so I may apologize if some slides are repeated, but this nonetheless is, I think, a relevant topic, and it's standardization. So these are my conflicts of interest. So standardization, what does it mean? Well, in global speaking, is implement a standard for a complex intervention based on current accumulated knowledge, consensus, and evidence. Now, how do we standardize such a complex and such a controversial thing as recruitment? First, there's no consensus and no evidence whatsoever. And there's already 30 years dealing with the same concept, but still there's no consensus and evidence, so it's very difficult to come to standardize such a procedure without this consensus. So, and what should it aim at standardization? What do I think we need to achieve? We should be able to systematically repeat a similar principle to be applied in patients, so it becomes interoperability, so physicians do the same with the same aim and concept. It should be safe and efficient as much as possible, and of course it should improve the quality. And the next important or difficult task is how you match this with individualization, which we know is important. When it's almost a contradiction with standardization. But standardization, I mean to set the basis, the principles to apply this in a proper way in the clinic. So even though there's no consensus and it's controversial, it's actually a very frequent used adjuvant intervention, as the SAFE study showed in 2016, used more frequently before the COVID pandemic, of course, than, for example, the prone positioning. So it's used, and for me, this high use of recruitment means that physicians perceive that it might be useful, or it's useful in the treatment of ARDS patients. So what do I mean also with standardization in recruitment? So first of all, you need to put recruitment in its proper place. So it should be a part of a rational lung protective ventilation strategy. So if you're not doing this, or if you're not put it in this context, if you only use it for improving your oxygenation, you maybe abandon this effort because probably is no use in using this interventions at the bedside. So then you need to assess that the lung is collapsed. So obviously it is futile to recruit a lung that has no collapse component in its pathophysiology. And then try to assess the potential for recruitment, individualize the recruit maneuver and the PEEP titration. That's also mandatory. And confirmation, this is also where I talk a little bit more in detail. So we need to establish that what we are doing to the lung and to the respiratory system and to our patients has an aim, and that we are achieving this goal in order to improve the mechanical or the protective conditions of the lung for mechanical ventilation, and also important to apply a de-escalation strategy. So if you look at the latest RCTs on recruitment in ARDS, the OLA trial in 2016, the ART trial in 2017, and then the FARLAB trial, actually all these studies lack of any kind of standardization. So in none of these studies, the presence of lung collapse or the recruitability of the patients was assessed. So there was a lack of proper individualization in most of the trials, with small differences between them. There was no clear confirmation of an interventional goal, so was the open lung actually achieved or not? And there was no clear de-escalation strategy, so the perfect scenario for failing in a trial, especially the ART trial, which actually was a big failure. So let's see, what about the assessment of collapse and potential for recruitment? This is actually quite complicated in the clinic. We have different methods. We have imaging like CT, of course. This is not a truly clinical bedside method, but of course it will tell you the distribution of aeration and the presence of collapse. Mechanics, and there's some attempts to establish the recruitability of the lung based on several interventions. For example, the recruitment to inflation ratio recently described. Lung ultrasound, which is readily available in most ICUs nowadays and is easy to use, and actually allows to identify a consolidation pattern, so confirming the presence of collapse. And a coming technology that is luckily more and more available in the clinic is impedance tomography, which can assess the presence of collapse by the redistribution of ventilation to the ventral parts of the lung, and also by looking at the plethysmographic change, for example, in the levels of the changes in the levels of aeration, which means the unexpected lung volume, with different levels of pressure. So these are available now, but still, you know, for all these interventions, to assess whether this collapse is recruitable or not, you need to do some kind of intervention. And, you know, in the recruitment to inflation ratio, you need to make a bigger PEEP step. In the CT, you should pressurize the lung. So, and this may not sound very scientific, but I think from a clinical perspective, probably the best thing you can do is recruit the lung, make a formal recruit maneuver, and assess the response. I think it's the best way to come clear whether this patient is responsive or not, and looking at specific goals. So individualized recruitment and PEEP, and I had the opportunity to participate in the development of this automated recruitment tool, which tries to include the knowledge, the accumulated knowledge from the last decades of how we should theoretically recruit the lung in a more safe and efficient way. So it allows the user to establish under certain limits the recruitment pressures, the recruitment times. It automatically shifts to a PEEP titration phase, and to identify the closing pressure and recruits the lung again. So first, the recruitment phase. It's important that we are just including here the cycling pressure control ventilation recruitment, which should be the only maneuver you should use in the clinic. There are many studies showing already that in the past, more frequently used CPAP maneuver is not good for you, it's not good for your patient, it's not good for the hemodynamics, it's not good for the lung, and it's usually not as efficient as a cyclic maneuver that allows us to stepwise increase the PEEP and accommodate the lung to the recruitment pressures, increasing the safety. So CPAP should actually be abandoned, and we do not recommend it in the tool. PEEP titration is based on a decremental PEEP trial, and then also the user has some possibilities to change the settings or to adjust the settings to a specific patient. And we use this in our multi-center trial. We are participating here with our chairman and Bob Kaczmarek. And you see here that in this trial, we had the opportunity to use a more specific tool, which allows us to have a trend over the changes in compliance on a breath-by-breath basis. And this, I think, made a very important difference, because this is the most sensitive part of any recruitment strategy, is to identify the level of PEEP, because this is the working pressure of the respiratory system for hours to come after you optimize the lung. So it's important that you don't miss this, and you, just for looking at the ventilator screen, miss the important values of PEEP that the patient needs to have. So we had a trend in improved mortality, but it was a pilot study. So let me put you some clinical examples. Here's a ventilator-associated pneumonia. This is the ventilation of the patient. We adjust the recruitment parameters here, and then we press the go button, and the system performs the recruit maneuver. And you see here that the system mathematically, and this is also a very nice feature of this tool, mathematically identifies the point of maximum compliance, eliminating a certain subjectivity of the physicians, because sometimes it's not easy by even looking at the graph to identify the point of maximum compliance. So here, in the context of this decremental PEEP titration, the closing pressure was detected at 8, so the system recommends a pressure of 10, a PEEP level of 10. And you see here, this in Spanish, before and after, that we had a gain in compliance. So there was a good exercise, because we could improve the effective volume of the lung, reduce compliance, and ventilate this patient in a more gentle way after recruitment. So here's the before and after. And you see here we have actually a reduction in PEEP. So this intervention allowed us to adjust the PEEP to the lower end. So from 12 to 10, with a better compliance, with a lower plateau pressure, and this in the hopes that we could maintain this for the hours to come, ventilating the patient. Another interesting feature of this tool is that we are seeing things that we usually did not see. And it's not only seen by me when I'm at the bedside, but it's seen by anyone that can record this. And this is a very clear behavior of the lung. So in the context of a decremental PEEP trial, if you see this behavior, you see here that the compliance is continuously increasing after a recruitment maneuver. So this means that the patient probably has a very, very, if at all, little amount of collapse. Second, that the patient does not need PEEP. So he's not responsive because he doesn't need it. The patient doesn't have collapse. And third, and most importantly, so you can scratch out recruitment from the strategy of this patient, because it does, without collapse, without needs of a higher PEEP, you don't need to test this patient again for recruitment. And by the way, this has been a very common behavior in the COVID patients during the pandemic. Another example, this is a very sick patient. You see after intubation, he became severely hypoxemic. So we had to stabilize the patient and then recruit him, and he was a quite large patient, so we applied quite high pressures at the beginning and started the PEEP titration with 22. And here we have this other behavior, also very characteristic. So the patient obviously did not respond because we couldn't identify a point of maximum compliance. You see a continuous decrease. And again, in the context of this standardized decremental PEEP titration, this means two things, or we must assume two situations. Either the lung was not recruited, so we did not reach the opening pressures of the lung, or the outset PEEP level for the PEEP titration was not high enough. So what we did here is to reset the parameters. So we increased the recruitment pressure 5 centimeters of water, and we increased the PEEP level to 26 in the decremental PEEP titration. And after the performance of the maneuver, you see here that now we have a response. The patient was recruited now, and you see that the closing pressure was at 22. So we could convert a non-responding patient to a responder. And this had a traduction in better oxygenation. And of course, this is always a clinical decision, whether you want to or you need to restore the volume and you want to ventilate the patient then for a longer time with high levels of PEEP. And then, of course, it becomes important. And as a matter of fact, in this patient, we introduced a esophageal catheter to be sure that the transpulmonary pressures were in a proper range, but also to de-escalate the treatment. So a few examples of COVID patients, and this has been very, very characteristic, very low levels of PEEP, 10 centimeters of water, 8 obese patients needed a little higher levels of PEEP. And this is just a recording of 9 fully recorded decremental PEEP titrations. And you see here that the PEEP set by the clinician was actually a little bit higher than the PEEP the system provided, so a systematic and a standardized way of recruiting. So PEEP could be reduced in 62% of the patients. It had to be increased by a mean value of 3 centimeters of water in 28% of the patients, and it could stay the same in 10. And then overall, we had an improvement in compliance and a decrease in plateau pressure and a decrease in driving pressure in these patients. Finally, this confirmation maintenance. And then I want to switch a little bit to another world of recruitment, which is the intra- or postoperative atelectasis. So this study, led by Carlos Ferrando, analyzed the effectiveness of an open lung strategy and how this could influence in the reduction of postoperative pulmonary complications. So then you have to realize that postoperative or intraoperative atelectasis are very easy to recruit. So these patients are usually good responders, even though they were abdominal surgery. The intervention is not so complex, but this was a rigorous, let's say, protocol, reaching opening pressures with a decremental PEEP titration. And the study was a little disappointing because we did not find any difference between this and the conventional standard ventilation with a low PEEP and a conventional tidal volume in the development on postoperative pulmonary complications. And this puzzled us a little bit because, of course, we were disappointed with the result, and we performed a secondary analysis of this. And then we thought, well, is it possible that these patients were not recruited, even though we had this specific protocol? And we put this data together with another study, and we were analyzing where Carlos Ferrando was analyzing the effects of oxygenation on the infection of surgical wounds. Together, 1,480 patients. And then we had to define somehow the situation. And of course, it's not the optimum, but we said, well, if intraoperative blood gas was taken, if the PF ratio was above 400, we could declare the lung as open. So with this criterion, with its limitations, to our surprise, half of the patients in the open lung arm with this specific protocol, highly responded patients, didn't have an open lung. And in the conventional treatment, 1/3 of the patients, 30%, 33%, actually were totally open. They had no atelectasis. There was no need for doing anything. And I think this is important not only for future trial designs, because you cannot assume, and this is something we know, you cannot assume that just by applying a strategy you will achieve your goals. And secondly, for the clinic, because you probably are recruiting patients that do not need it. So you see here that then when we defined the patients with a response, with an open lung, actually we had a significant differences in the amount of pulmonary complications and a composite of severe pulmonary complications. So, and my last slides here is the de-escalation strategy, and I've said this already 2 times. I think this is important, and also standardization will allow us to actually, on a daily basis, assess the situation and try to reduce the PEEP accordingly, with improvement in lung function as the increasing compliance here is showing. So just to finalize, I think here the words of Henry Ford, I think this is a work in progress, and we need to set some basis, some minimum common denominator to do things in a proper way, try to assess what we do. And before this is not clear, I'm not sure that it is worth to make another randomized control trial on recruitment strategies. Thank you very much.
Thank you very much, Fernando, because you have sent already very important messages, especially when you reanalyze data that have been published. And people think that it's negative, but it's negative because, in fact, many patients don't need to be recruited. So I think you have to... Yes. From one question, only a time from one question. A practical question, if somebody is interested to make a question, I don't know. Anybody? So I think the message that you said about the clinicians do recruitment maneuver to patients who don't need it. Yeah. In a very high proportion. And in fact, you discover, or you have identified, that in many of those patients, even the PEEP level that was recommended, according to the recruitment maneuver, or whatever the study you use, it was lower than the PEEP that the patient had before the recruitment maneuver.
Yes.
So what is now the message, forget about the slide, the clear message to the audience when they treat patients with ARDS?
Well, I try to, the message is the global presentation, because I think recruitment is a good option available for the clinician if collapse is an important component of the pathophysiology, because this is something you can fix, you can revert, and you can improve the mechanical condition. But we need to assess it and improve our tools for assessing at the bedside, because otherwise we cannot pretend that just by applying a certain fixed intervention that we will achieve a goal. This was clear for us in the study, so we need also to assess the response. And then you can be much more specific and direct your efforts in those patients that really need it, and avoid stressing patients that do not need recruitment. And of course, if you look at the whole spectrum, the ARDS patients are the most sick ones, and luckily enough, not these last 2 years, but luckily enough, these are not so frequent. But there are many patients that have collapse and that can benefit, at least at the beginning of mechanical ventilation, from such a strategy in order to improve the protective conditions. But again, not in a systematic way to everyone. Just select your patients. And it's striking, these last 3 trials, all what I was trying to consider important as standardization was just ignored. So I think then we are talking about very different things, and it's impossible to compare apples with pears.
Again, we go again to the individualized care. So, okay. So I think we have no more time to continue with you, Fernando. It's very interesting, but we have to continue.
Yes, it's my pleasure to introduce again Lise Piquillot, still from Lausanne, I assume, and she's going to discuss improving patient-ventilator interaction in patients with ARDS.
Thank you. The question now is, how can we improve patient-ventilator interaction in our ARDS patients? Of course, when we switch them to assisted ventilation. Again, here my conflicts of interest. We have some challenges when we switch our ARDS patients to assisted ventilation. First, those patients usually have very high respiratory drive because they have poor gas exchange, high CO2 because of increased dead space, abnormal ventilation over perfusion ratio because of increased chant. They also have pain, anxiety, discomfort, and inflammation by itself increases respiratory drive. Second, our ARDS patients, at least the most severe ones, have a restrictive respiratory mechanic because of fibrosis, because of atelectasis, and maybe also because of edema. And both high respiratory drive and restrictive respiratory mechanics lead to patient ventilator asynchronies when we switch our patients to assisted ventilation. What happens here in the second respiratory cycles? Has someone changed the ventilator mode? Is there an inspiratory effort performed by the patient? Or is there a problem of matching between the duration of pressurization and the neural inspiratory time? The answer is that there is an inspiratory effort in the second breath. And this is what we call flow asynchrony. And of course, it's very frequent in our patients when they awake and are still in volume assist control, which is the mode used here. The predisposing factors for that is high respiratory drive. And also, when you set a low inspiratory flow, because your patient would like to have more, he increases the drive and then also has this type of asynchronies. Here, to explain a bit more in details, you have here the passive situation and the volume assist control. Here you have an inspiratory effort with moderate intensity, and here a very strong inspiratory effort. And you observe that you have changes in the aspect of the P airway time curve. And this is related to the presence of the effort, because the effort generates a negative pressure that gives a different shape to the P airway time curve. This can be improved by improving your ventilator settings, basically by increasing inspiratory flow in volume assist control. And sometimes you can improve the situation by switching to a pressure-regulated mode, because in this situation you have a decelerating flow and the very initial flow during inspiration is higher. But be careful if you do that. There is a high risk of having high tidal volume, because tidal volume is going to be determined by both the intensity of the effort of your patient and by the amount of pressure you deliver by the ventilator. This was the first thing you are going to have in your ARDS patients when you switch them to assisted ventilation. And this is the second thing you observe very often. What is that? Ineffective efforts, late cyclings, double triggerings, or double triggerings and premature cyclings. And my answer is that we have two problems: double triggerings, there is one here, and probably premature cyclings with very short pressurization time here. If we try to classify patient ventilator asynchronies, we can say that there is one first group that is flow asynchrony, already discussed. There is a second group here that is called reverse triggering. This is something like reflex contraction of the diaphragm to a pressure delivered by the ventilator, and this is mainly in deeply sedated patients, and it's not the patient we are discussing right now. In the patient we are discussing right now, awake patient switched to assisted ventilation for some times. What we are going to have is what I've called here classical asynchronies, which are asynchronies related to the triggering phase and to the transition between inspiration and expiration. And in ARDS patients, what you have is double triggerings and premature cyclings. What is double triggering? Double triggering is when you have two pressurization with a short time between the two that occurs during one inspiratory effort. This is easier to see here when you have airway, flow, and electrical activity of the diaphragm, which is the respiratory drive. We very well see here that we have two pressurization during one single patient breath. And this is a problem for our patients because this can lead to high tidal volumes, and that we don't want. This can also be very uncomfortable for our patients, then further increasing the drive and further deteriorating the situation. Predisposing factors are high respiratory drive, long and intense breath here, restrictive respiratory mechanics, too low amount of assist that lead to high inspiratory drive also, and short pressurization time because of the ventilator settings you've chosen. And what is premature cycling? Premature cycling is a short cycle. Pressurization time is shorter than the neural inspiratory time of the patient. You can see them on the ventilator screen because they are very short, and if you look very carefully on the curve, you also can observe those abnormalities in the shape that is suggestive of premature cyclings. Again, much easier to explain and to observe if you have the patient inspiratory effort displayed on the ventilator screen, but usually you don't have this at the bedside. Here again, there are predisposing factors: high respiratory drive, restrictive respiratory mechanics, low level of assist, and short pressurization. How can we improve synchrony when we have that on the ventilator screen? Maybe we could decrease inspiratory time. Maybe we could try to increase inspiratory time. Maybe we could just change the trigger sensitivity. Or we could decrease the level of assist. My answer here is that we should find a solution to increase inspiratory time, because basically pressurization of the ventilator is shorter than the neural inspiratory time of the patient. Then we have two types of asynchronies in our ADS patients. They have the same predisposing factor. High respiratory drive, not very easy to deal with. Restrictive respiratory mechanics, you cannot do anything. Low assist, you can try to increase assist and see whether it's better. And short pressurization time, you can act. And the solution is increasing the duration of pressurization, either directly, if you are in pressure assist control and have the opportunity to set inspiratory time. It's possible in some ventilators. And if you are in pressure support ventilation, you have to play with the expiratory trigger setting. I'm just going to explain that a bit more in details. Here, you have pressure support ventilation. You recognize trigger with the threshold you set in the ventilator. Then you have pressurization with the slope, the time that is needed to reach the amount of pressure support you deliver, and then the delivered support at the pressure support level you've set. And finally, you have the transition from inspiration to expiration. During pressure support ventilation, this transition is managed by the reduction of inspiratory flow. Practically, the system detects the maximal inspiratory flow here, then looks at the decreasing phase, and as soon as a set value is reached, a percentage of the maximal value the system opens the valves and allows expiration. And this can be set on the ventilator. In this picture, it's the by default value, which is the physiological one of 25%, 1/4 of the max. And how is the situation in your restrictive patient? On the left part of the slide, you have a normal patient with normal respiratory mechanics. With an expiratory trigger at 25%, you have a good matching between the time of pressurization and the neural inspiratory time that is displayed here in green. In your restrictive patient, the situation is different. Your restrictive patients, because of the big elastic recoil, has a very fast decrease of inspiratory flow, here in orange. And you see that if you keep 25 as the expiratory trigger setting, the pressurization time is very short. And the only solution to increase this pressurization time and to have a value closer to the neural inspiratory time is to change the threshold for the transition between inspiration and expiration. And that means that if you choose a low value, 10% here in the example, sometimes up to 0% in severe ARDS patients, you can match the duration of the pressurization with the duration of the neural inspiratory time. And this suppresses early cyclings and helps suppressing double triggerings. And if it's not sufficient, what can you do? You can try to play with the slope. Here you have a standard setting with a slope at 100 milliseconds, quite fast pressurization. And on the left, you have a situation where the slope is put at 300 milliseconds. It's very easy to see that pressurization here lasts longer than here. But this is true only if the intensity of the effort doesn't change. This is the case here because this was recorded on a model, on a bench test, with exactly the same effort. And if you have the same effort, you can increase the pressurization time by choosing a longer slope value. But in the real life, if you change the slope, you can have an influence on inspiratory drive, and sometimes it's not very easy to predict what is going to happen to your pressurization time. Then basically, you have to try, and if it's better, you are happy, and if it's not, you can even try to do the opposite. And sometimes that also is not sufficient, and you still have a lot of double triggerings and a lot of premature cyclings. In this situation, you can consider using pressure assist control and set the inspiratory time if you can. Then you can correct the problem of early termination of inspiration related to the restrictive respiratory mechanics. Of course, in pressure support, pressurization duration depends from the expiratory trigger you've set, but also from pressure support level, patient inspiratory effort, and slope. And when you've played on all those parameters and haven't solved the problem, then you have to choose another solution to set the inspiratory time of the ventilator. Then patients recovering from severe ARDS have high respiratory drive and restrictive respiratory mechanics. This is the reason why they have a lot of asynchronies, and particularly premature cyclings and double triggerings when you switch them to assisted ventilation. Flow asynchrony is frequent. You can solve the problem by increasing the inspiratory flow and sometimes by changing the ventilator modes. And when you are in pressure support, think about changing the expiratory trigger threshold, even to very low values. This can improve patient ventilator synchronization. Thanks for your attention.
Thank you very much, Lisa, for this very clear and comprehensive overview. Are there questions or comments from the audience? So perhaps I can start. I mean, you have, well, explained to us all the different types of asynchrony. So what do you think is the real clinical relevance of identifying and correcting these asynchronies in the patients? Does it affect outcome in one way or another?
Definitely, we don't know. There is an association between poor synchronization and poor outcome, but the cause and effect relationship is still a matter of debate. But what is clear is that in those specific patients, double triggerings lead to high tidal volumes. Right. And that, for all other reasons we know, we should not tolerate that. Then I really think that in those patients, if we have poor patient ventilator asynchrony, we can have a worse outcome.
And do you think that, I mean, recently a couple of trials have been published on the NAVA mode, a mode that is known to improve patient-ventilator interaction, and so I think the Chinese trial and the trial by Jesus suggest that there's improved outcome. Is that related to better patient-ventilator asynchrony, or how would you interpret that?
I would say that it's one of the explanations, maybe not the only one, because another advantage of NAVA and PAV is to avoid over-assist. And those patients are difficult to wean and can be worsened if we deliver them too much assist. And I think that there are two explanations. And those patients can be managed with NAVA.
Right.
We've managed some of them in the pandemic, it's possible.
But still, it seems very reasonable to look for the asynchronies and try to correct them as much as you can when the patient is on the ventilator, right?
Yeah.
Okay, thank you very much. I think we should move on.
Yes, we are going to the last talk of this session. We are proud to introduce Philipp Lepper from Hamburg in Germany. He's going to talk about don't forget the right heart. So I'm going to I assume that you are going to talk about the right thing to do, no?
Hopefully. Well, thanks for the invitation and thanks for the possibility to speak. I assume most of you need to go to the next lecture, but I will keep it brief because the message is short. Don't forget the right heart. I can probably skip most of this because this is quite clear. Why do ARDS patients die? Most of them, especially probably during COVID-19, died of septic shock. And acute right heart failure is a common problem. In a study by Meconso, it was up to 22%. And if you look at other studies, it's even higher. Of course, a failing right heart does not lead to an improved systemic perfusion because the right ventricle is, so to say, the weakest part of the cardiovascular system. And the right ventricle is quite sensitive to changes in pre- and afterload. ARDS might increase afterload in various ways. Some of them are just noted here, and of course positive pressure ventilation and PEEP also contribute to the increase in afterload. So the right ventricular function is not considered important at all for systemic hemodynamics until it becomes important. There are actually 4 categories of right heart failure defined, and we must never forget that left and right heart are interdependent because they share an interventricular septum. They have common myocardial fibers and they have a common pericardium. So there is no left heart success in right heart failure, and I'm not sure if this was correctly attributed to Professor Takala, but I heard it from him. And in a recent publication from the Netherlands, there were 4 categories for right heart failure defined, and I would assume that patients on the intensive care unit are generally at risk, so there's probably no patient that's not at risk. So these patients should be assessed for right ventricular dysfunction or right ventricular failure. They might be hypoxemic more than we would expect from the lung disease alone. They show signs of systemic congestion, signs of right ventricular dysfunction per se. They have a low cardiac output and they show changes in clinical chemistry values. Probably the most easily to identify value is lactate because it comes with all the blood gas analysis, but also troponins and transaminases are helpful to monitor these patients. The definition of right ventricular failure, right heart failure is difficult and it's not clearly defined. So one of the previous speakers talked about standardization. There is almost no standardization for right heart failure, but it's obviously a state where the right ventricle is substantially dilated and the central venous pressure is elevated, and we have a change of the right ventricular and left ventricular ratio of the end diastolic ratio, and we can measure some other features, especially in the echocardiography. And from my point of view, but I have to confess, I'm a pneumologist, not a cardiologist. From my point of view, this works with transthoracic echocardiography, and I just summarized some of the key findings over here. So an assessment of the inferior vena cava or the right ventricle in the 4-chamber view is probably sufficient to detect, especially over time, changes in right ventricular function. It's clear that all of these values that are mentioned on this slide, there are problems associated with. So a normal TAPSE can definitely occur in patients with severe pulmonary hypertension, no problem. And still the right ventricle is already compromised. There are clear risk factors for acute right heart failure in ARDS. And interestingly, these are all factors that we heard about in previous talks. The driving pressure, in this case, over 18 centimeters of water, hypercapnia and bad oxygenation, especially in patients where the origin of ARDS is pneumonia, are problematic for the development of right heart failure. And in fact, one of the easiest measures to unload the right ventricle is probably prone position, despite the fact that, as Antonio Pezzenti already said, it's not entirely clear how prone positioning works. So what is good for the right ventricle is good for the lung, but I assume it's also the other way around. What is good for the lung is also good for the right ventricle. Actually, I want to, for time's sake, skip this slide. What it just shows is that increasing transpulmonary pressure over, let's say, a more or less physiological level leads to distension of alveolar vessels, and they will largely contribute to afterload of the right ventricle. So if transpulmonary pressure increases, it's just less and more on the x-axis, this will increase the afterload and then lead to or make the right ventricle more prone to fail. In COVID, it might be slightly different. This is a study from Italy, where actually pulmonary vascular resistance was not elevated in these patients at a relatively high cardiac output. Most of these patients, 76%, had a pulmonary hypertension, but it was always, in this study, post-capillary. And I just showed this because, funnily, it showed just the same values and also independent from the other group, showed that it was mostly a post-capillary problem in COVID-19. So what should be the plan of action in right heart failure in ARDS patients? Well, first we have to assess the severity using clinical, biochemical, imaging, and maybe invasive markers. We should identify and treat triggering factors, for example, sepsis or septic shock. If, for example, COVID-19 patients developed an overt right heart problem, it was mostly in situations when they got a bacterial co-infection, for example. And of course, arrhythmias can be a triggering factor that should be corrected. Optimize the fluid status. What does that mean? For most part, it means diuretics or renal replacement therapy to reduce the volume. But in some instances, it can also mean that we should cautiously give some fluid, but always avoiding fluid overdistension and avoid giving volume when the patient is non-volume responsive anymore. Then, of course, flow is important, but pressure is also obviously important. Maintain the arterial perfusion pressure by primarily using norepinephrine. That's actually the recommended vasopressor. Vasopressin might influence a little less the pulmonary artery, so from my point of view, it can also be used in this situation, especially if you have invasive monitoring, such as a pulmonary artery catheter. Then inotropes that help to unload the right ventricles, ventricle could be used, such as levosimendan, dobutamine, or milrinone. And if that's not enough to prevent the progression of right heart failure, then consider further measures for afterload reduction, such as inhaled NO or prostacyclins, or maybe pulmonary hypertension specific drugs, for example, Viagra, yeah, sildenafil, thanks. I think I have to skip this for time's sake as well. CO2 retention is also a problem, and as already indicated in the previous talk, when physiology ends, so to say, when it's not possible to get rid of the CO2, then maybe an alternative oxygenation or decarboxylation is necessary, such as ECMO or extracorporeal CO2 removal. To already sum up, if the patient is at risk for right heart failure, keep the driving pressure below 18. I mean, that's something we should do anyway. Decrease the CO2, improve the oxygenation. We heard a lot of good ways to do so in the previous talks. Avoid acidosis and hypercapnia. And don't fluid overload the patient. Assess with, for example, echocardiography. Don't give additional volume in overt right heart failure. Use selective pulmonary vasodilation to improve oxygenation, and use prone positioning, because that's a really effective measure to unload the right ventricle. And only in the last instance, consider ECMO, because probably every patient without an ECMO is better than a patient with ECMO. We can skip that. And so I would like to conclude defining right heart failure at the bedside is definitely a challenge. Right heart failure, however, is a frequent entity in ARDS patients, so it deserves some attention because it also increases the length of stay, morbidity, and mortality. So I hope I could convince you to not forget the right heart. Thanks for your attention.
Okay, so thank you very much for being on time. I think this session is going to be finished after 1 or 2 questions from the audience. And I think that this is an important issue. Anyway, this is an important lecture. I have a question too later on.
Yes.
Try to, because sometimes they try to put it close to your mouth.
Yeah, okay, thanks. So talking about ECMO patients, is it frequent the need to shift from VV ECMO to more complex configurations like VVA or VV plus VA due to impending or overt right heart failure?
Well, actually, I don't know what your experience is, but from my point of view, it's not that frequent that you have to use VVA ECMO. It might be due to the fact that VV ECMO itself alleviates hypoxic pulmonary vasoconstriction, and that you can control for hypercapnia by VV ECMO itself. Sometimes we switch patients to VVA for a couple of days, but I would say it's not that frequent. But the risk increases from my point of view with duration of the ECMO run. So if you have like 10 to 12 days, it's probably not going to be a problem, but with longer runs, maybe.
Okay, Philip, I would like to make a comment and a question. So, you know, the clinicians are now rediscovering that patients, especially because of the COVID, the patients with severe ARDS, they had, you know, pulmonary filling defects, thrombi. But this is something was already reported in the late 70s, early 80s, so with other types of ARDS, no? Now, do you think that now, because you say it's important, the right heart is important until somebody, noticed that, you know, that before was not important until the patient died. So do you think that many patients who died with the inceptive shock or in shock, an unresponsive shock, they die because they have right heart ventricular failure? Due to the thrombi that we cannot, because we are focusing a lot on the alveolar side, but we forget, or we forgot the ARDS exists because you have first endothelial injury. Without endothelial injury, ARDS does not exist.
Yeah. Well, actually, in the COVID patients, the overall pressure was not elevated, but of course, it's obviously a heterogeneous problem. So there might be areas where, especially around the infiltrates, where you have extensive endothelial destruction, and other areas might be relatively unaffected. And this might make up for, so to say, a stable total pressure. As for example, it is possible in heavy exercise when cardiac output increases a lot. But I think it's definitely the case that patients in septic shock, with or without COVID, die from undiscovered right heart failure, but the proportion is very difficult to make up. But I would just try to make a guess and say it's 10% of patients that die with unidentified right heart failure.
Especially today that we don't have the pulmonary artery catheter, you know, we don't measure the resistance, we don't calculate, sorry, the pulmonary resistance. And that is an issue, it's a problem.
But the right heart catheter is not a bad device.
Right, it is. Okay, so I think Leo and I would like to, thank you for being here. And now I think we have to finish the session. And thank you again to the speakers and you.